Okay, take it away, Dr. Regis, for this exciting grand rounds.
All right, good afternoon, everybody. It is my pleasure to welcome Dr. Tracy Crane. Dr. Crane is an associate professor of medical oncology, public health, and kinesiology at the University of Miami, the co-leader of the Cancer Control Research Program, and director of lifestyle medicine, prevention, and digital health at the Sylvester Comprehensive Cancer Center. Dr. Crane leads a multidisciplinary research team to carry out the delivery of lifestyle interventions across the cancer continuum, many of which utilize digital health solutions such as wearable devices. Dr. Crane is a registered dietitian and received her PhD in nursing science from the University of Arizona. She serves as the Vice Chair for Cancer Prevention and Control for the National Cancer Institute's Community Oncology Research Program for NRG Oncology, and she's the principal investigator of several large National Cancer Institute and Patient-Centered Outcomes Research Institute trials. Please help me in welcoming Dr. Tracy Crane.
Thank you so much. I'm sorry I'm not there in person. I heard we're back to giving grand rounds in person sometime, but I'm actually in Chicago for my NRG oncology role, so I appreciate us letting me do this by Zoom. So let me screen share here. You can tell me if you see it. Let's get it to presenter mode. Are we good?
Yep, once you put it, yeah, perfect, thank you.
Okay, and then I'm going to minimize my screen so I can actually see my slides here. All right, so I'm excited to present our research here that we've been building here at the Miller School of Medicine, and really the topic today is focused on, can we utilize nutrition and exercise to enhance therapeutic response in cancer care? I have nothing to disclose. So I like this image because when I think about what I do every day, I think about it in terms of, can we complement what we do in medicine with our traditional therapies? And so I think about it with the lifestyle lens of how can nutrition and exercise do this? And, you know, since this is a provider-focused series, I would say that many of you are probably asked by patients, no matter what your specialty, what they can eat, how active they should be, and then how prepared are you to talk about that? Do you have time to talk about that? And so I think this is where a lot of our research in our lab sits, is how do we best provide evidence that during, in my case, active care for cancer treatment, can we provide these recommendations as a prescription to improve outcomes for our patients? And so today, hopefully I can take you through this journey that we're on in our own lab, trying to build the evidence. And I think as you think about your own discipline and your own practice, how some of these things might be able to be applied in your own case. So our objectives, just briefly, understand the role of nutrition and exercise in cancer treatment, integrate the evidence-based nutritional and exercise interventions, what there has been done to date, and then recognizing barriers and strategies for maybe how we can implement these programs better in our practice. So I want to start by talking a little bit about the American Society of Clinical Oncology. So there was a large series of papers, 3 papers to be specific, and it started in about 2019, where we published a survey that went across all the ASCO oncology providers. And it was really looking at what was their attitudes and their practices of addressing diet, physical activity, and weight management for patients with cancer. And we were not specific about, was it during active treatment, not active treatment, just in general, in their practice, what did they do? And so the majority of oncologists, did say that they felt it was important. It's a critical piece. But when it came to actually being able to recommend them, there were several barriers. 1 is time, and 2 was the availability of programs. And so part of that is what drove, part of what I do every day is reading these papers and working with this team, that we need programs that are accessible. So keep that in the back of your mind as I go through these next few talks, or these next few research studies that we're doing. So the next paper that we actually were part of is Attention to Diet and Exercise, and we surveyed patients. So we surveyed over 2,500 cancer patients from across the country, and we asked them, during your cancer care, and we were more specific this time, did you have any advice given to you by your provider about nutrition, exercise, or physical activity, or weight management, and after your cancer care? And what we found is that even if providers told the patient that you just need to be, think about your diet, engage in physical regular activity, manage your weight, they were 80% more likely, just with a simple recommendation, to be doing those things later. So we also assessed their behaviors. And so that really speaks to the power of a clinical provider just acknowledging and recommending these things. And then finally, this was last year, there was a large ASCO guideline put out. And what they did is they looked across the literature and really rigorously looked to see how many trials are there that are being actively conducted during treatment that focus on exercise, diet, and weight management, and what have their outcomes been. And what they found is that for aerobic exercise, we actually have decent evidence to say that it's safe and patients should be doing it by and large, with a few exceptions, during active treatment to improve symptoms. For exercise, they could not find any definitive papers that have been published to look at outcomes such as relative dose intensity, chemotherapy completion rates, or even long-term survival during active treatment. Diet and weight management, there were literally almost no papers that had been published that were conducted during active treatment for cancer. And so what the guidelines came away with is that this is a serious gap in our knowledge. So the NCI actually responded partially to this, and this building evidence of lack of knowledge, that we really needed to better understand what role does diet and exercise have during active care for cancer treatment. And so you'll see here, they actually have the INICTO Consortium. This stands for the Exercise Nutrition Interventions to Improve Cancer Treatment Outcomes. And what the vision is of INICTO is really to improve cancer care through exercise and nutrition. And how can we rigorously test, because this is the key, how can we rigorously test similarly to how we test, pharmaceutical agents or drugs, and to really show what kind of dose we need and what kind of interventions we need during cancer treatment to improve outcomes. So you can see that Miami down here, we are one of the few sites. There are 4 U01 sites. We are one of them. And this trial is called TEAL, and this is going to be the first trial that I talk about. So as I walk through today, I'm going to present 3 different intervention trials that are being conducted right now at the University of Miami, all during active treatment. The first one is going to be TEAL. It's in ovarian cancer, which is a solid tumor. The next one is the lymphoma trial that is being administered during chemotherapy for lymphoma. And then the final one is going to be FASTER, that is during active treatment for newly diagnosed metastatic disease and patients taking CDK4/6 inhibitors. So this is TEAL. I have the pleasure of leading TEAL with Melinda Irwin, who's at Yale. We have an amazing team of investigators that work alongside us. And then just to set the stage a little bit and put everybody on the same playing field, risk factors for ovarian cancer include age, use of fertility treatments, having a family history of a genetic syndrome, smoking, and then overweight or obesity. And I really want to focus on this because the key piece of TEAL that I want to focus on for this portion of the talk is body composition. So with ovarian cancer, we know that this is the rates at which ovarian cancer is diagnosed. Unfortunately, majority of ovarian cancer cases are diagnosed at late stage. And we know that although 5-year survival rates have improved dramatically, it really matters when you're diagnosed and your survival. And so these numbers in the dark, in the black, show that if you're diagnosed with distant disease, your 5-year survival rate is about 30%. So this is not good. And there's unfortunately disparities by race and ethnicity. So the 5-year survival rates have actually declined for Blacks. And then we know we have a poor overall survival for Hispanics compared to non-Hispanic whites. Critically important for our catchment area. And all-cause mortality is greater at 56% for Blacks and 41% for Hispanics. And when we actually control for completion of chemotherapy and access to care, we know that there are still differences in survival. And this really led us to think about, along with some other trials we had conducted, to think about maybe there's a role of lifestyle here. Maybe there's something going on that we can try to help improve. So treatment for ovarian cancer, it's pretty straightforward. You either come in and you do surgery right away and have adjuvant chemotherapy, or you come in, you have a few cycles of neoadjuvant chemotherapy, and then you have surgery, and then you have your formal cycles. The good news is 80% will have a complete response after 6 cycles of chemotherapy. This is the good news. And we know that, remember I said we're going to focus on body composition, that muscle composition measured by CT scan is a predictor of overall survival in advanced ovarian cancer. So in this paper, you can see the top dark line is where they've optimally debulked somebody and they had high levels of lean skeletal mass, versus down here at the bottom, this is where they were not optimally debulked and they had lower levels of lean mass. And what you can see here is that low versus high, when you have no residual disease, they actually had 3.3 years versus 2.8 years of survival. And even when they had residual disease, this still helped, showing that this is really lean mass is really a powerful component in predicting overall survival. So increased risk for loss of muscle mass and sarcopenia, it's highly, highly prevalent in ovarian cancer. So upwards of 68% of patients will have sarcopenia. This is associated with an increased risk to chemotoxicities. Again, for teal, this is one of the key mechanisms we're focused on, and it reduces survival. The good news is that CT scans are routinely ordered as part of cancer care for ovarian cancer patients. And so this is a tool that we have in our toolbox, so to speak, where we can actively assess this readily on routine scans. And it's something we are doing in teal. One thing we think about, though, is quality of muscle more important than quantity of muscle? So we know the absolute amount of muscle mass is important, but what about the quality? And so this is looking at the association of each of the different body composition measures and risk of death in ovarian cancer patients without adjustment, with and without adjustment for ages in these. And you can see when you look, the SMA stands for mean skeletal muscle area. The SMD stands for skeletal muscle attenuation or density of the muscle, which is kind of a measure of quality. SMG is skeletal muscle gauge, and then skeletal muscle index is the overall. A lot of times when we look at papers, they publish this SMI when we look at the CT scans. But in fact, if we start digging a little bit deeper, you can see that this density is more likely to be significant and being predictive, as well as the skeletal muscle gauge. And again, we see the similar things years to following. So after surgery, you can see we have better outcomes in the patients that were younger and had better muscle quality. And we know that preoperative sarcopenia is associated with poor survival in advanced ovarian cancer. And this is relevant for teal because we know that 50% of our patients are going to have neoadjuvant treatment. And so we have this unique opportunity to really look at, can this intervention I'm going to share with you in a minute act as a prehab in terms of intervening before surgery starts, and can we see any changes to help boost this muscle mass before they go into surgery? The other thing that I want to share about teal is that we are using kind of a more novel approach to body composition. So not only are we taking the routine scans and measuring the body composition, but we also have something called D3 creatine. And D3 creatine, our body has a total creatine amount in our muscle mass. And so if we give deuterated creatine, it's a pill that they swallow. We collect a fasting urine, they swallow the pill, and then we collect it 2 to 3 days later. And we have a dipstick, just like a pregnancy test, and we freeze it and we can ship it off. And we're able to measure the direct assessment of muscle mass. It's been validated, it has a strong relationship. I will tell you that we've enrolled now close to 30 patients. We don't have any problems with women doing this. This is the first time I've used this method, and I was a little bit hesitant to think, would they swallow the pill? Would it be okay? And nobody has refused this, and we've had really good uptake. So I'm very excited about what we're going to see with this, because we not only have the CT scans, but we'll also have this measure of D3 creatine. So the part of the mechanism of action that's really driving teal is that we know that chemotherapy delays and dose reductions are a problem. So in ovarian cancer, upwards of 50% of women will experience some kind of dose delay. There was a study of 222 women, and those that had less than a 1-month delay, their average progression-free survival was 44.5 months, versus women who had a 1-month delay. On average, their progression-free survival time was 18 months. That is a huge difference. So chemotherapy dosing and delays are very important. So in a NICTO, we look at something called relative dose intensity, and all 4 of the U01 trials have the same primary endpoint. And so relative dose intensity, it's the ratio of actual dose intensity to projected dose intensity, and we have it as a percentage or proportion to the amount of drug planned to deliver per weeks. And so we know we had to have some sort of cut point for ovarian cancer patients. And so there was another study that was done in 170 women, and 46% had an RDI less than 85%. They had a 94% higher mortality rate compared to women who had a higher than 85% RDI. And so for teal, our primary outcome is set at 85% or higher for the RDI. So consequences, we know that women with ovarian cancer have extensive abdominal surgery, that debulking surgery is extensive and leaves them with quite a bit of healing that needs to happen. We know that we have a reparative state. So even if you're going in for, planned surgery, it's still a wound, it's still things that need to heal, it's still going to be causing things like increased inflammation, damage to peripheral nerve cells because of chemotherapy. So we do this surgery, we have this chemotherapy, we are impacting quite a lot, not only to impact skeletal mass, so we know they have risk at decreased skeletal mass, but also all these chemotoxicities, peripheral neuropathy, cognitive impairment, GI symptoms. And this is what we are saying is leading to potentially these reduced relative dose intensity of chemotherapies. So nutrition and exercise, we were hypothesizing, maybe can reduce these chemotoxicities and improve the completion rates. We know that physical activities inversely associated with chemotherapy-induced peripheral neuropathy. We also know that exercise can attenuate cognitive impairment, sleep disturbances, arthralgia, fatigue. There's been fewer studies really looking at the impact of nutrition on ovarian cancer outcomes. The LIVES trial is another trial we ran after completion of treatment that's getting ready to publish their findings, and that will be one of the first trials that have actually done this. Diet modifications could also improve GI symptoms in women. So there's an ongoing trial in rectal cancer that we kind of utilized to design our trial that was showing that in fact, when you had a plant-based diet or a high fiber diet, you can actually improve these GI symptoms. So how we believe these mechanisms of exercise and nutrition are really improving treatment outcomes is the TL intervention. So we're looking at, can we improve body composition? So we know that exercise can improve physical function, diet and exercise can help to preserve lean muscle mass, and we also know that diet and exercise can increase strength, it can increase mobility, and it can decrease recovery time. We know that patient-reported toxicities, diet and exercise can reduce systematic inflammation. I've already mentioned exercise can improve a number of these symptoms. The diet quality may be able to improve GI symptoms. And then meal timing in relationship to chemotherapy dosing may in fact improve nausea, vomiting, and improve appetite. And so these are all the key pieces that we believe our intervention is going to be designed to touch upon and really to improve relative dose intensity and lead to fewer grade 3 or grade 4 toxicities, subsequently reducing the chemotherapy dose. So here are our specific games. We have an 18-week medical nutrition therapy and exercise intervention versus an attention control. It's a very diverse sample of 200 women. They've been newly diagnosed with ovarian cancer and they are starting chemotherapy. So as I mentioned, aim 1 is the relative dose intensity. Aim 2 is looking at these patient-reported outcomes. Aim 3 is the body composition. And then aim 4 is really looking at how the diet, the exercise, the patient-reported outcomes, and healthcare utilization at 3 months post-chemotherapy and 12 months post-diagnosis. So really trying to understand, can these actually improve some of these long-term outcomes? Here's our study design. So as you can see, we have women that are newly diagnosed. They're coming into the treatment. They get 18 sessions. Those 4 booster sessions are added on in case they are neoadjuvant, because there is a time period after surgery where we really can't exercise with them at the same rigor as we were if they are adjuvant and after surgery. We can see here we do a baseline assessment prior to the start of chemotherapy as our goal. Post-chemotherapy, we go 3 months after and then 12 months after. And then, as I mentioned, we have neoadjuvant versus adjuvant, we are split about 50-50 on each of these. So here's kind of the counseling sessions you can see. So we have 18 sessions in total, these booster sessions. Really the difference here is at month 1 in adjuvant treatment, they will have already had surgery and they're starting chemotherapy versus a neoadjuvant. We're really looking at, they have surgery in the middle of it. But again, one of the exploratory outcomes we have is in the case of neoadjuvant treatment, do we see some sort of prehab response if we intervene before surgery? So here's our intervention. We have, as I mentioned, they are tackling both diet and exercise. We're really promoting more than 5 servings of vegetables and fruit a day, 25 grams of fiber. There's a specific emphasis on protein. So protein's at about 1.2 to 1.5 grams per kilogram of body weight, having them watch added sugars, drinking plenty of fluids, and avoiding alcohol intake. And then our exercise interventions we try to get them to 150 minutes of moderate or 75 minutes of vigorous activity. They do twice weekly strength training sessions. 1 is supervised with an exercise trainer. 1 is done on their own. We do give them resistance bands. We meet with them. There's a resource library of different activities and videos. We give them a Fitbit, and then they also meet with a dietitian once a week during the session. We also try to get them to reduce sedentary time and increase their daily steps to about 10,000 steps per day, measured by the Fitbit. So our progress to date, this is how we're doing. So overall, we have actually 31 now, I think, are or actually, we actually have one more than this. I think we have 44 now, but we are in the lead here. So thanks to, we have an amazing GYN oncology team. And so I have to shout out to them because they have been incredible to work with and really collaborative. All the nurse practitioners, all the nurses, the doctors, it's been a really amazing experience. But we do have 20 patients who have been randomized, 10 to the intervention, 10 to usual care. They have about 11 that have completed, and we have 30 patients already that have completed. So ovarian cancer is a pretty rare cancer. So even getting to the 200 number is going to be one of the larger interventions that have been done to date. It is definitely the first intervention that's ever been delivered during chemotherapy treatment. So in summary, women with ovarian cancer are at elevated risk for these dose reductions and chemotoxicities. It significantly increases their risk of progression and death. Evidence suggests that this lifestyle intervention may improve these chemotoxicities. And what we know is that women with ovarian cancer are really motivated to participate. If I didn't show you, if I go back on the slide, we have a very high conversion rate of people who are eligible and who actually consent, higher than what we see on other lifestyle intervention trials that are perhaps maybe in longer term survivorship periods. So women are very interested in trying to see what they can do. I think it's perhaps a way to be able to contribute to their care by being able to have some sort of control over their lifestyle. So now I'm going to shift gears a little bit. So this was all teal. I really tried to focus in on what we're doing with body composition, how we measure it, why we think it's important. And now I'm going to shift to the lymphoma trial that we're running. So this is the lymphoma trial. It's called LIFE-L. I lead this trial with Dr. Moskowitz and this amazing team. It's funded by the V Foundation, and it is also ongoing. Some background, we know that there's about 80,000 new cases in non-Hodgkin's, fewer Hodgkin's lymphoma cases. The lymphoma treatment modalities individually or in combination often lead to negative physical and psychosocial symptoms and side effects. However, we know little is known about the potential of lifestyle impact. And so in fact, when I first started writing this trial with Dr. Moskowitz, we searched the literature and we could not find any interventions that had been done with lifestyle interventions in lymphoma. We know, however, though, that in other cancer types, breast, colorectal, that lifestyle factors such as diet and exercise have been shown to improve these symptoms, leading to long-term better outcomes. We know that fatigue, when I talk with Dr. Moskowitz and his team, we know that fatigue is one of the most common side effects that's reported by patients. And lymphoma patients actually have some of the highest reported rates of fatigue during chemotherapy at about 43%. It's more likely to be reported during treatment, and then severe fatigue is actually reported in about 37% of Hodgkin's lymphoma patients. We know that it's associated with impaired progression-free survival and overall survival. Patients reporting severe fatigue at greater than 5 years are more likely, are less likely to be working. They are more likely to experience financial problems and have increased healthcare utilizations. And so we felt like, okay, let's focus on how can we improve not only completion of treatment, but can we really focus on fatigue? And then also really be one of the very first lifestyle interventions that have ever been delivered for lymphoma patients during treatment. So this is kind of where we think our mechanism of action is working in terms of improving fatigue with diet and exercise. So we know that we can have an impact with diet and exercise on inflammatory markers. We also know that we can modulate the gut microbiome and that diet and exercise can play a role there. And that really focuses up on this, we have the blood-brain barrier axis here. And so we are kind of hitting it two ways. One, we're trying to get to the cognitive portion of sickness behavior with fatigue and all these symptoms, but also from a circulatory level, trying to improve blood inflammatory cytokines. So when we look at what's been done already, this is the Exercise as Medicine and the American College of Sports Medicine. And we know that there is significant evidence that during cancer treatment, and not during treatment, but for cancer survivors, that we have strong evidence that we can improve cancer-related fatigue with aerobic and resistance training. And so we thought, okay, this is where we're going to really focus our exercise intervention. And in terms of diet, it's associated, we know that a Mediterranean type diet is associated with a lower likelihood of having persistent fatigue. There's been some trials done in breast cancer survivors that looked at higher quality diets, high in fiber, low in total fat, high in fruits and vegetables, and really specifically, I'll draw your attention to really being high in omega-3 fatty acids relative to omega-6 fatty acids. So we're really looking at what is that ratio. And so this is where the Mediterranean diet comes in. I have to say that the moderation of red wine, I would actually throw that out the window. People don't really like it when I say that, but I think that needs to be probably not good for our cancer patients. But really the focus is being active every day, trying to get these really healthy fats in your diet, and then limiting the red meats and sweets. So the study design for LIFEL is we're looking for 120 patients. We are doing a baseline assessment. They have a 2-to-1 randomization. It is given during chemotherapy. So we draw blood before they start chemotherapy, and we consent them and get them going, take all of their measurements. And they are getting either a Mediterranean diet and supervised home-based exercise, or they're getting a waitlist control. They have an assessment at pre-cycle 3, so midway through. So unlike teal, we are actually trying to collect some data midway through, because it's not well characterized in any cancer, for that matter, that what is really going on with these behaviors during the life cycle of treatment. Then we also do an assessment pre-cycle 6, and then we do another assessment 4 weeks later. And similarly to, not to teal, but we are really looking at, because there have been no trials done, we really didn't have anything to be able to power a primary endpoint on. So we're really looking at first feasibility, and our goals being we want to get at least 50% of eligible patients enrolled, 80% completion rates of the intervention sessions if possible, the retention rate, and then we're looking at satisfaction. And then our secondary outcomes are relative dose intensity, and then looking at fatigue, cognitive function, depression, and neuropathy. So how are we doing? Again, I should have been working in lymphoma my whole career, because it's been amazing to see how fast we've been able to enroll. I think really speaking to, 1, the support of the providers, and 2, the interest of patients. So we've had 186 screened, 54% have been eligible, and about 77% have enrolled. So well above that 50% threshold we were looking for. And I will say that the #1 reason why people don't enroll in this trial is because they're feeling overwhelmed. Very reasonable. So how are we doing? This is where we're at. We've enrolled 76 patients onto the trial. We're trying to get to that goal of 120, so we're close to almost being done. They're about 52 years of age. Their BMI is about 28, higher likelihood of being male. And then we have a really nice diversity in our sample in terms of Hispanics. And we are offering, I should have mentioned this before, we are offering the trial teal in Spanish as well as LIFEL. So all of our trials are available in English and in Spanish. So how does this intervention differ than the teal trial? So this is really focused on a Mediterranean diet. So the focus here is really trying to get servings of legumes up, which is very specific, trying to get servings of nuts and seeds up, and then trying to get fatty fish, which is, when you're going through chemotherapy, can be quite the challenge. And then exercise goals, we're trying to get them to 150 minutes of moderate to vigorous activity, and then again, strength training twice per week. Similarly to teal, they have weekly calls with a dietitian and an exercise physiologist. We do it all home-based, so they can stay in the comfort of their home and complete these activities. They also get a Fitbit, the resistance bands. And so how are we doing? So nutrition's a little bit better than exercise, but not much. We're almost at that 80% completion rate. You know, as I mentioned, there's been very few trials that have really focused on nutrition and exercise during treatment. So just learning what people are willing to do, when do they feel bad, you know, should we be changing, you know, should we not even be asking them to work out the weeks of their chemotherapy? So all those little nuggets of information are really critically important in all of these trials, because it's just not been done before. So I want to focus on a little bit, think back to teal and the protein intake and the body composition. So the orange line, this is just very preliminary data. It's not powered yet. So this is just initially what we're seeing. So you can see that in the intervention arm, we're getting nice protein intake. We're actually seeing an increase. So patients who are in the control condition are actually decreasing their protein intake without the help of a dietitian, and the patients in the intervention arm are actually increasing, which is great, because we're really focused on that, trying to maintain body composition. Nuts and seeds, we're getting them up to over 1 serving per day, which is great. In the intervention arm, the monounsaturated fats, again, this is directly linked to these good fats in both groups are going up. In both cases, this is largely being driven by the fatty fish and the nuts and seeds. So we have amazing changes there. Our moderate to vigorous physical activity are increasing over time. I think that it'll be really interesting to overlay our Fitbit data with our symptoms and then when chemotherapy is happening. Like, I can't wait to write that paper and look at those data, because I think there's really drastic changes that are happening over time with people's just regular daily activity, as well as when they feel like they can exercise. But you can see that we are increasing light to moderate and strenuous activity. At baseline, this is where the 2 arms are. Control is green, orange is the intervention. And then post-chemotherapy, we really are getting the light activity up better, and then moderate and strenuous a little bit lower, but still, I think there's also a message of, can we even get people to maintain and not lose over time if they are exercisers or they are doing something? I think maintenance is also a key piece here, not just, single level improvements. Depression and anxiety, or pain rather, you can see here that our patients in the intervention arm, post-chemotherapy, the depression rates are coming down, the pain levels are coming down. And then fatigue, this was the one that we were really interested in trying to help out. And what we see is that fatigue is significantly going up in the control arm. It's still going up in the intervention. We certainly are not stopping the fatigue, but it is at a much slower rate. Now, these are starting at different rates too. So once we have a fully powered analysis, this could shake out a little bit differently, but for right now, this is what we're seeing. So in summary, patients receiving treatment for lymphoma are at elevated risk for treatment-related effects, including side effects, including fatigue. That's really been our number one focus here. There's a lack of interventions that are focused on lifestyle behaviors for patients with lymphoma. There's, like I said, there has been nothing when we wrote this trial, couldn't find a single paper. And then even during treatment, patients are motivated to enroll, participate in these interventions, and be actively engaged. If I had time to share qualitative feedback, I would say that people really enjoy this. They feel good, they feel better. I think even the physicians have seen improvements when they see the patients on a regular basis that are participating in the intervention. So I feel strongly that these are good data to support a larger randomized controlled trial in the near future. LifeL, I didn't have time to talk about it, but we are also measuring body composition on them, not with the D3, but with their PET scans. So things that we look to do in the future are looking at metabolic tumor volume in relationship to their body composition, as well as we are collecting blood and storing blood. We have several plans to run inflammatory markers. Dr. Lopez Pentecost is going to be with Dr. Lombard is running metabolomics on these individuals. So we just will be lots and lots of data that will be swimming in the very near future. So the final trial I want to talk about is really this focus on moving towards patients who are diagnosed with advanced disease are living longer. That is great. It's one of the things that we hope for. But when we think about how they're living longer and can we improve those outcomes in patients in the metastatic setting, this is where the FASTER trial comes from. So the NCI also feels very strongly about that. There was a specific RFA that was put out focused on patients with advanced cancer. And so Sylvester and us were lucky to be fortunate that we were awarded one of these grants. I think there were 6 of them that were given out. So this is FASTER. It's a fasting and exercise study for women with advanced breast cancer. My MPIs are Christina Daly-Conright and Jennifer Ligabell at Dana-Farber. And we have co-investigators at ASU, as well as people focused on body composition, Michael Rosenthal at MD Anderson, and I have to shout out Carmen Calfa because she's our breast oncologist on this trial. So FASTER is led by Dr. Yalvaberg and our CRC, Richard Ramos. And the focus of FASTER is really, again, this focus on fatigue, improving physical function, reducing side effects in patients with early stage breast cancer. We know that's very established in the literature. We know that exercise, I already showed you the American College of Sports Medicine. We know that exercise can improve fatigue. Again, there's been a lot of research done in early stage, but there's been less done in advanced stage breast cancer. We know that preliminary data, there's been some work done in ketogenic diets and prolonged fasting prior to chemotherapy could reduce toxicity, but compliance to ketogenic diets is quite low. And fasting for extended amounts of time prior to chemotherapy, patients will do it, but we don't have great data on long-term uptake and being able to sustain it. So an alternative to this is something called prolonged overnight fasting. And so you think about when you stop eating in the evening, and then when you start eating the next day, and we do it overnight to try to help people has it be easier if you're asleep, you don't know that you're fasting. And so we really try to get patients to fast for a 14-hour window. And so this is well tolerated. We know it's associated with improvements in treatment-related toxicities, including fatigue, physical function, depression, and anxiety. And we know that this may be mediated via reductions in inflammation as a result of aligning people's circadian rhythms. So circadian rhythms really can, when you eat in the morning is one of the #1 drivers of circadian alignment. Outside of the sun coming up in the morning, when you eat your first meal can really help drive these signals of circadian rhythm. And there's very few data that have been collected to really rigorously test how this alignment may attenuate treatment-related side effects. So we ran a pilot trial a couple of years ago. We enrolled women with metastatic breast cancer. We enrolled 30 total. They had baseline measures. They underwent a 12-week intervention of prolonged overnight fasting and strength training and exercise intervention. And then we looked at post-intervention measured. We had 80% of planned participants who were enrolled as a goal. We wanted people to reach 70% of days fasting and at least 70% of them completing the exercise. So we ran this trial. One, COVID happened during the middle of it, and two, we PI3 kinase inhibitors were much more prevalent or commonly given, and so we had 17 that were on CDK4/6, 13 that were on a PI3 kinase inhibitor. 27 patients completed the intervention. 84% met the pre-specified goal of achieving at least 13-hour fast on 70% of days. The exercise increased by 73 minutes per week. And so we had 40% of patients that achieved the aerobic benchmark. Unfortunately, only about 18.5% achieved the resistance training. Again, this happened during COVID, and we had originally wanted them to come into the clinic to do the exercise. And so there's a lot of shifting. So we did have good data, though, to show that fatigue was improving and some of these other things like insomnia and physical function. So that led us to write the FASTER grant. But what we really wanted to know is we didn't really know which of the key components were really improving this. So we designed a 2x2 factorial design to really try to tease apart what is it that is improving and that's changing these outcomes. So we consent these patients prior to them starting a CDK4/6 inhibitor, because PI3 kinase inhibitors are no longer used as often. And what we found was actually patients who were starting the CDK4/6 inhibitors showed better outcomes. So we decided, and more patients take them. So we're focused on the CDK4/6 inhibitors. They're randomly assigned in this 2x2 design. So they either get supervised exercise and prolonged overnight fasting, fasting alone, supervised exercise alone, or a supportive care intervention. It's a 12-week intervention. This is partially designed because patients routinely come in at these every 3 weeks. And so it was a nice time to bring them back in to have another measurement. We always try to match our assessments with standard of care visits. So we collect the post-intervention measures at 12 weeks. There's a 6-month measurement and then a 12-month measurement. And so really what we're looking at is we're trying to get to the circadian alignment. So prolonged overnight fasting plus minus the exercise, and that's really going to impact our primary outcome is fatigue. Our secondary outcomes are focused on sleep, treatment toxicities, patient-reported outcomes, physical function, and body composition, because again, they have routine CT scans, so we're collecting all those CT scans to run body composition. And then our tertiary aim is really to look at circadian activity rhythms, fatigue, sleep, depression, anxiety, quality of life, and then physical function and body composition. And we really believe that the circadian alignment and trying to align rhythms is going to be what's helpful. So we know that our prolonged overnight fasting intervention, our objective is to get people to 14 hours, 6 of 7 days per week over this 12-week period. I can tell you that most patients get to that in about a week's time. It's pretty easy to do. Intervention, they get weekly calls to the dietitian to help support them. And then they have daily recording in a journal, a mobile journal, or by paper if they want, or texting, where they can record their stop and start times of eating. And then they also receive a fitness tracker at 6-month follow-up to enhance retention if they are part of this other group. So the feeding and wake cycle, so if they're in fasting alone, they are really only focused on the fasting. If they're in fasting plus exercise, they also get the exercise intervention. Here are some of the mechanisms. We know that when you're awake, you have increased muscle fatty acid uptake, glycolytic metabolism, lipogenesis, we have glycogen synthesis from the liver, everything's awake and doing things. Versus when you're sleeping, we can see all these different mechanisms of action that are happening. We have lipid catabolism, leptin secretion, glucagon secretion. And so really, we're trying to utilize when people take their first meal of the day to help and train the circadian alignment. So the supervised exercise intervention, we're really pushing to try to get them to 3 weekly aerobic and strength training sessions per week. And this is all supervised with a trainer because it is a very short time frame of only 12 weeks. So we really try to and we're trying to tease apart in a 2x2 design, what is the key dose and what is the key exposure that we need to see these differences. So initially we train them in person. We may go to their home. They get an exercise bike that's sent to them. They get to keep. They get resistance bands, as well as what we call, these blanking on the word, but they're dumbbells that can be changed out. And then we also give them their Fitbit. Our supportive care group, and I should mention too, in the supervised exercise intervention, we are trying to get them to exercise during daylight hours. So again, back to that circadian alignment, we're trying to get them to be active in the day and be resting at night. So we also try to ask them to exercise during daylight hours. The supportive care group gets printed materials about diet and exercise from the ACS. They have every other week supportive care calls from the University of Miami, and then they receive a fitness tracker again at 6 months post to try to encourage retention in the study. I will say this is an important piece of it because a lot of times when you run these trials and you're just providing support by picking up the phone and calling somebody with these psychosocial outcomes and some of these other outcomes, you need to be able to know like what caused the shift. Is it just talking to somebody and having extra support during a really rough time? Or is it, what is the actual effect of the intervention? So that's why we have this supportive care control condition. So this trial is our newest trial. So we opened to enrollment in April. We now have 7 patients randomized. It's been a little bit, there was a little bit of a shift in CDK4/6 inhibitor giving out medication that now it's also given in the adjuvant setting. So it's been a little bit more work to identify patients who are actually metastatic with advanced disease. So we've screened over 400 patients. We've had about 7 that have been randomized. And you can see we have nice differences. I think really important is that even in our first 7 patients being here in Miami versus and also having our site at Dana-Farber, that we are getting people who their country of origin is different. And I think that we're going to be able really to learn a lot about differences by race and ethnicity simply by being able to offer the trial in Spanish, and then also just given our really unique catchment area. You can see here they do a VO2 max. So we actually have this cardiometabolic cart in our lab. This is our trainer, Stefan, practicing and getting ready to go. And then this was actually our first patient. We got her all set up with her exercise bike at home. And had her first training session. So now we're at a good pace and we're getting, our goal is to get 3 patients per month per site to complete the trial. I don't have enough time to talk about how we deliver these interventions, but I wanted to at least put one slide in to talk about what we've done to build the infrastructure to be able to deliver these remote interventions that have wearable devices. So this is something that we call My Wellness Research. It was developed here within the Sylvester and the UHealth infrastructure. It's a digital tool that really enables patient-centered communication and remote data collection for research participants. It centralizes communication, so you can actually have, if you do all your communication through this dashboard, no matter how you communicate with the patient, whether it's text, automated voice response, email, or video conference calls, every single touch and exposure is recorded. This is important when you look at behavioral trials because you need to know what the dose is that is being delivered of your intervention to know what do you really need to deliver the next successful intervention or scale it for scalability. The patients can also send it back to us as well. So we bring in all of the video messages, text messages, any of the phone calls. It's pre-programmable. So if you have an intervention that you want to be delivering a message on X day about eating fruits and vegetables or exercise or symptom management or whatever, you can actually program for this to send out messages at a certain time point. And it really allows for these very low touch interventions that can be highly scalable. You can see on the right here, this is how we have a dashboard. This is what it looks like. This is a real dashboard. It's got a test patient, not a real one. But you can see coaching sessions up here. You can see engagement adherence. You can also see the activity that's been going on. You can see when we talk to them. You can see their steps per day. We can pull in all kinds of data from the different things. It's highly customizable. We can do everything from a log, which is shown down here at the bottom. This one is actually, I think, the teal one, or maybe I think that's teal. But it actually can be customized. So for example, for LIFE-L, the lymphoma trial, we actually have a separate column that's got your nuts and your seeds and your fatty fish. For the faster intervention, this log is simply when did you start and stop eating? So highly tailored. You can also collect symptoms. I mean, it doesn't have to be diet. It can be symptoms. It can be whatever you want to collect data on a regular basis. And then data management. This is where we all struggle, I think, as investigators. At the end of the day, like, what do you do with all this data? We have Fitbit data coming in. We have patient-reported data coming in. We have all kinds of data. So this allows for custom reports and CSV files. And I would just say that it's available to be used. And we have it used on several trials, and then several other investigators are utilizing My Wellness Research now. So I'm going to wrap up here. I think I'm on time, but key points. So there's a variety of ways that we can manipulate diet intake and daily activity. I've shown you a couple different ways, everything from modifying a food pattern to increasing a certain type of macronutrient like fatty, good fats, also to meal timing, as well as different interventions for exercise, strength training versus aerobic versus just moving more. I just contributed to a paper where we were just looking at simply 5,000 steps per day was this threshold that we see in older patients. This idea of 10,000 steps per day, maybe we need to get people moving more, and the message needs to be 5,000 steps per day. So being able to measure all these things and study them, we're at a really exciting point, I think, in lifestyle medicine. I think patients are really interested and they want to know more. I think it's evidenced by the number of patients we get who enroll and the conversion of eligible to consented. And I think all of you probably get asked these questions on a regular basis, and it's a way people can contribute back to their care. And then rigorous testing of these behaviors. I didn't get into the nitty gritty, but I tried to show the software platform, but we are really trying to measure the exposure of diet and exercise at the level that we would for a drug trial to know what is the dose that it takes for these behaviors to be complementary and improve the outcomes of our more traditional treatments. So in summary, I think that we're finally to the point where we're starting to build the evidence where it's gone from like a nice to have, but really it's a must have. I think we can't ignore these behaviors in our traditional medical settings anymore. Simply talking to your patients about what are you eating and how are you exercising, or what's your activity look like, and recommending that they do it. I think patients sometimes don't know if it's safe for them, and just 3-minute conversation or less, 90 seconds, could really improve these outcomes. And then following the data, if you're interested in this area, I think we have Sylvester, and the Miller School is one of the few places that has 3 trials running, maybe the only place that has 3 trials running during active treatment, really focused on these lifestyle behaviors. So I expect that we should have a significant impact on the field in the near future. We have tons of data. So if people are interested in supplements or, come talk to us. We have stored blood on every trial. We have Fitbit data. We have Actigraph data, diet data, you name it, we probably have it. So I'm very collaborative, and we're very open to working with people. These are my acknowledgements. I know the slide's crazy, but I tried to get everybody. If I didn't get everybody, I'm really sorry, but I have an amazing lab that I couldn't do any of this work. The only way that we're super successful is this lab team that I have, and I have great collaborators. I have to say that I came from a previous institution where the collaborative spirit of the clinicians was not there. And this has made all the difference. So I'm very grateful for everybody who works with me and helps us recruit patients and get these patients on trial, because it really just completely changes the trajectory of these trials. And this is a year in our lab. This is 1 year worth of photos from last year to this year. We do fun things together. I think when you work hard, you have to play hard. So this is our team. And with that, I will take questions.
Dr. Crane, that was excellent. Very, very important topic, impactful. And I know you'll get lots of inquiries from those of us outside of the oncology service line who can see applicability to their diseases as well. One question I'll ask, which may be a little bit unpopular, but I remember years ago going to the doctor as he or she was smoking a cigarette, telling you not to smoke. How important and what data do we have on providers that actually practice what they preach, in terms of do we know that the most effective clinicians in getting adherence to diet and exercise are those practitioners who themselves do it? Is there any way to assess that? One thing is to talk about it for 60 seconds or 90 seconds, but the other thing is to really believe it.
Yeah, so I think that for sure we know that there is higher likelihood of recommending it if you're practicing it yourself. I don't know the data specifically on like the numbers of providers who are actually practicing these healthy behaviors versus those who are not, but I suspect it looks similarly to the rest of the United States if I had to guess. But I think just even having the awareness, and that I think you don't have to be perfect, right? it's just trying. It's just continuing to make those small incremental changes would be the message I would give, because it's hard, right? It's not, this is not easy to do, but we know that if you can practice what you preach, you're more likely to talk to your patients. I know one of the most interesting papers I ever read was actually providers, and I think they were internal medicine providers, but don't quote me on this, but they actually looked to see how much more likely they were to recommend patients losing weight based upon the previous patient's weight. So if they saw somebody previously with a BMI of like 40, and then they saw somebody with a BMI of 35, they were less likely to recommend weight management for that patient with the BMI of 35, because the influence of the prior patient was influencing what they had just seen. So I think that's a really fascinating area to think about, because you see so many patients in a day, but it's human nature to compare, right? I mean, I have the living experiment of having twins in my life, right? So I'm always, even though you shouldn't compare your children, right? But I think even in practice, that's something that happens. So I don't know if I answered completely, but I would say that I know that you're more likely to do it if you're doing it yourself. I would say that little changes add up to big changes over time, and that, you know, try to approach every patient with the same you need. And there's also this idea of like a fit fat, right? I hate that term, but I don't know what else to say, but somebody can look thin and have a very different body composition, have a terrible diet, but genetically. So I think addressing it with everybody is probably what I would say.
Thank you. Dr. Chediak, your hand is raised.
Yes, thank you. That was fantastic. I really loved it. And one of the things that struck me is, as you're in training circadian rhythms, you're also probably enhancing sleep, not just with diet and exercise, but also the circadian components of it. And I wonder, I think it would be worthwhile to take a look at your Fitbit at night and look at where the sleep improves and to what extent and how that might play, you know, what role that might play in tolerance to therapy and overall well-being of this patient population. And if you need help with that, I know a couple of people in my division that would be very happy to help you think about it and work on it.
Yeah, I'll definitely reach out. We do have a sleep measure across all the trials, I believe. And then we have Fitbit data across all the trials. And then we also have on Faster, the one that's really focused on circadian alignment. We actually have them wear two actigraph devices, one on the wrist and one on the hip, so that we get good data from both the hip and the activity from the hip and the sleep from the wrist. So that is definitely something we are very interested in, looking at the circadian alignment. Thank you.
Dr. Marcus, you had a comment in the chat. Do you want to unmute yourself and ask it? You're muted, Erin.
Sorry. I was wondering if you could comment on weight training and hematologic malignancies specifically.
So there's very little data. I think the LifeL trial is probably the first trial that is actually delivering a strength training intervention. There may have been a small pilot trial I missed, right? You don't ever know if you see all the data, but I cannot think of any off the top of my head. But strength training, you know, we have it in the heme malignancies in LifeL with lymphoma, but I would assume that it would work well in leukemia and myeloma as well. That I think strength training is the up and coming darling of the lifestyle medicine world, right? Like, we've been so focused on aerobic activity, but now our understanding of body composition and how important it is really driving this push towards more strength training. And so having better, higher quality lean mass and preventing decline over time. I mean, a lot of these patients are older too. And so we know that, you know, in an older aging population, you also have, you know, decline in muscle mass. So I would say it's very important. I think it's safe. I think, you know, we are still doing the studies to know what kind of dose we need, but having somebody, you know, we have great support services here. I would highly recommend, we have fitness classes that are offered. We have strength training classes. They're safe. They're designed for survivors. I would say, you know, encourage patients to do those, but strength training, I think, is very important across the board, across all malignancies. I think there are some special nuances, like in our advanced metastatic disease. You know, we are very cognizant, if you have a lytic lesion, we're not going to, in metastatic bone mets, we're not going to have you do certain strength exercises. So you have to, you know, there's definitely cases where you got to be more careful, but broadly speaking, I think strength training is important and it's safe to do.
Okay, well, thank you, Dr. Crane. Thank you, everybody, for attending. I call your attention to the chat, where you'll be able to find the link for CME and MOC. and look forward to seeing everybody next week. Thank you very much again, Tracy. Enjoy
Thank you. All
Chicago.
right,
Bye.
thank you. Bye-bye.